Okay guys, we'll start with the first question. Identify the device which is shown in the image. Come on guys, what is the device which is being shown in the image? This is a Goodell's airway. It is also called as a oropharyngeal airway. Okay, Goodell's airway or oropharyngeal airway, which is used to keep the airway patent. In patient who's unconscious, if you want to restore the breathing, if you're not able to intubate or not able to put the laryngeal mask airway, you can put a Goodell's oropharyngeal airway, but make sure that the patient is empty stomach. Why? Because patient might have gag reflex. It may instigate gag reflex. Okay. So oropharyngeal airway or Goodell's airway. Now regarding the oropharyngeal airway, one thing that we need to remember is what size oropharyngeal airway we use in the patients. You take the airway, keep between the tragus of ear and angle of mouth. If it is fitting between that area, you use that airway. Okay? So this is Goodell's oropharyngeal airway. One more airway device is there, which is nasopharyngeal airway, NPA. Now guys, what is NPA? Remember, OPA is oral airway, NPA is nasal airway. Imagine a patient is there who is having epilepsy, epileptic fits, he is having clenched teeth, and you feel that this patient's airway might be compromised. In that scenario, instead of oropharyngeal, because Goodell's airway cannot go, you can use NPA, nasopharyngeal airway. And how do you calculate the exact size of NPA? Keep between the tip of the nose till the tragus of ear. If it is fitting, then you have to use that size. But remember, if the patient is having any bleeding tendencies or base of the skull fracture, don't use this NPA. Okay. So the first answer was oropharyngeal airway. Coming to the second question, guys. Which nerve is being stimulated for the mentioned test over here? So first of all, what is the test that is being done over here? That is train of force stimulation, TOF test. Okay. And TOF test, what is the muscle that we commonly choose, guys, for TOF? It is basically the adductor pollicis. And the nerve is what? It is the ulnar nerve. Ulnar nerve. Everyone just look over here. If you apply train of 4 to me without giving any muscle relaxant, basically train of 4 yani ki you are giving 4 shocks and you are assessing 4 responses to the shock. So look over here. After applying this, I have not been received any muscle relaxant. So what will be the response, guys? When you give first shock, first twitch will come. Then second shock, second twitch. Third shock, third twitch. Fourth shock, fourth twitch. All 4 twitches are of same height. In patients who have not received any muscle relaxant, all 4 twitches would be of same height. Whereas, remember guys, if at all a person is given depolarizing muscle relaxant, imagine someone gave me scoline. Okay? Now after giving scoline is a depolarizing muscle relaxant. Now after giving scoline, they connected to the train of 4 ratio and they give the first twitch. Just look over here. First twitch like this. Second twitch same like this. Third twitch same like this. Fourth twitch same like this. Yani कि basically all 4 twitches. Remember, when I was not given any muscle relaxant, this was the response. This was the response, twitch response. When I have been received depolarizing muscle relaxant, how is it response? First twitch, second twitch, third twitch, fourth twitch. Yani ki equal responses. So if at all anyone is asking you, a person has been given depolarizing muscle relaxant, okay, how is the twitch heights? Just look over here. First twitch is like this, second twitch is also like this, third twitch is also like this, and fourth is also like this. Yani ki all 4 twitches are of decrease in equal height. So if someone asks you what is the train of 4 ratio for depolarizing, train of 4 ratio means what? T4 by T1. Okay? Yani ki 4 twitch by first twitch. Both heights are equal. So ratio will be what? It will be 1 in case of depolarizing. Whereas in case of non-depolarizing, imagine someone has given me a non-depolarizing muscle relaxant. What will happen, guys? Remember, after giving non-depolarizing muscle relaxant, first twitch like this, second twitch like this, third twitch like this, and fourth twitch very low. Yani ki basically, is it equally decreased? No. It is basically, remember guys, in case of non-depolarizing muscle relaxant, first twitch is like this, second twitch response come like this, third is like this, and fourth is very low intensity. So basically you will see a faded response. Train of 4 ratio in case of non-depolarizing, you will see a fade. And what will be the ratio when you compare the fourth twitch with first twitch? It will be less than 0.4. Less than 0.4. Remember, this is a ratio usually used for non-depolarizing muscle relaxant. Okay, or in case of adequate block also it should be less than 0.4. In case of reversal, while reversing the patient from anesthesia, what should be the ratio? The ratio should be more than 0.9. Now guys, which is the first twitch to disappear in the 4 twitches? Which is the first twitch to disappear? First or last one? It is always the last twitch. So remember, the T4 is the first twitch to disappear, and which is the first twitch to reappear once the muscle relaxant effect is gone? It is the first twitch, T1. T1. Okay, that's regarding the train of 4. Now guys, regarding this, 45-year-old man underwent laparoscopic surgery under general anesthesia. Post surgery, patient came to the surgeon complaining that he remembers all the conversation happened in the OT while he was under anesthesia. He told he was able to hear and feel everything but was not able to move. What monitoring could have prevented this? Come on guys. This is basically, remember, patient is having awareness during anesthesia. Patient came to you and he's telling that I was aware during anesthesia. First of all, why he was aware during anesthesia? Basically, you need to understand the thing that is required to keep the patient sedated during anesthesia, that did not work. What is the thing that is required? That is basically the inhalational agent. Inhalational agent, your inhalational agent was not enough, or your inhalational agent, it is basically stored in the vaporizer. In the vaporizer there was no inhalational agent, or it might be there might be inhalational agent in the vaporizer, but the MAC value that you were giving, it was not sufficient to the patient. In those scenarios, the patient might be aware but he is not able to move. Why? Because you have given the muscle relaxant. But how will you come to know your patient is aware during anesthesia? Patient will not tell, he won't move and all, but sometimes his heart rate might increase. Okay, BP might increase. That means those are some signs, but again it's not a clear indication patient is aware. Okay, for awareness monitoring, we go for a monitor called as BIS monitoring. In BIS, we usually attach some electrodes on the frontal head, and then we calculate the EEGs. EEG is nothing but electroencephalograph. We calculate the sum of EEGs. Okay. Yes, most of the patients, if at all they are having awareness during anesthesia, they will land up into PTSD. Okay. So this is regarding the BIS monitoring. So for awareness, it is the monitoring that is uses bispectral index monitoring. Now guys, regarding bispectral index, what we need to do is the values of BIS might come from 40 to 100. If at all you are getting a value of BIS is nothing but sum of EEGs. 100, if at all the value is 100, that means the patient is awake. Okay, 60 to 85 is the BIS required for sedation. 40 to 65 is the BIS required for surgical anesthesia. Surgical anesthesia. Okay, and less than 40 means the patient is too deep under anesthesia. Usually for surgical anesthesia, it is 40 to 65. Okay, now guys, as we are discussing something about monitoring, we also need to remember, apart from neuromuscular monitoring and BIS, we also monitor for patients' oxygenation, ventilation and circulation. Now guys, how will you monitor the patient's oxygenation? You monitor the patient's oxygenation by pulse oximetry. That is very, very easy. Just apply a pulse oximeter, which usually works on what law? It works on Beer-Lambert's law. Beer-Lambert's law. Okay, next you monitor for the patient's ventilation. How will you monitor the patient is adequately ventilated? With the help of capnography. Very, very important, guys. We'll discuss later what are the types of capnograph and all. Capnography. Okay, next you monitor the patient's circulation. For monitoring the circulation, you need to monitor for 3 things. One is the BP, one is the ECG, other is the transesophageal echocardiography. That is again not done for routine cases. It is only done for the cases or done for the patients who are posted for long duration surgeries or any cardiac surgeries. Okay, so in BP there is IBP and NIBP. Normally we go for non-invasive blood pressure monitoring, but if you are going for invasive blood pressure monitoring, then you need to cannulate the radial artery. And if you want to check the patency of radial artery, then you can go for a test which is called as Allen's test. Okay, next ECG. In ECG, 2 leads are monitored, guys. Lead 2 and lead 5. Lead 2 monitors arrhythmias and lead 5 monitors ischemia. देखो भाई, BIS monitoring is nothing but bispectral index monitoring. Okay, when a patient is during anesthesia, when the patient is aware, why the patient could be aware during anesthesia? If the inhalational agent that you are giving to the patient is not adequately reaching or it is not adequately acting, then the patient might be aware. How will you come to know patient is aware or not? By BIS monitoring. You just keep some EEG electrodes and you monitor that. You monitor the sum of EEGs. Okay. Lead 5, not lead 4. Lead 5 is for ischemias. And TEED, transesophageal echocardiography, it is a sophisticated monitoring. Normally, this T is used for venous air embolism. Okay. Venous air embolism के लिए use कर सकते हैं. Next is temperature. For temperature, there are two sides. There are two things, guys. One is the peripheral temperature monitoring. Other is the core temperature monitoring. Peripheral means normally that you apply the thermometer and you check it. Okay? Core temperature monitoring, there are sites, guys. Most commonly used site for core temperature is esophagus. Okay? But which is the most accurate site for core temperature monitoring? It is the pulmonary artery. But still we commonly use esophagus. Why? Because non-invasive. Esophagus is not invasive. Pulmonary artery means you have to put the catheter. It's an invasive kind of thing. Next, 55-year-old patient underwent left thoracotomy, requires one lung ventilation. Which tube is most appropriate? So when a patient is posted for any surgery under one lung, okay, and requires one lung ventilation, only one lung has to be ventilated, not both lungs. You require a special tube that goes into the bronchial lumen of that lung which needs to be ventilated. What is that tube called as, guys? It is called as a double lumen tube. Okay, when you put a imagine, guys, a patient is having cancer of this lung, okay, and we have to just ventilate the other lung. If I put a normal tube, both lungs will be ventilated. If I put a flexometallic also, again flexometallic will be going till mid trachea. Both lungs will be ventilated. So you need to understand, guys, for one lung ventilation, what is the tube that is being used? It is a double lumen tube. Okay. In double lumen tube, there will be a bronchial lumen and there will be a tracheal lumen. Once you place a double lumen tube, how will you confirm the exact position of double lumen tube? With the help of fiber optic bronchoscope. With the help of fiber optic bronchoscope, just look over here. This thing which I am holding in my hand, this is a fiber optic bronchoscope, guys. This is a fiber optic bronchoscope. Now just look over here. I have introduced the fiber optic bronchoscope and I am able to see the vocal cords. Okay. So basically remember, once you place a double lumen tube, the correct exact position of the double lumen tube can be assessed by fiber optic bronchoscope. Okay. Next, an RTA patient arrives in the emergency department with hypotension and active bleeding. The anesthesiologist plans for rapid volume resuscitation before shifting the patient to OR. Which of the following cannulas is? Come on, guys. Remember, a patient is there who is in shock. In shock, you need to give good amount of fluid at a high volume speed. If you use a 22 gauge, it is a very small cannula. You can't give high volume of fluid through this. You need a larger diameter. The largest of all is what, guys? It is 14 gauge orange cannula. Okay, 14 gauge orange cannula. Now, when we are discussing about the IV cannulas, we need to understand, guys, there are different sizes of IV cannulas, different numbers and different volumes. All we have to remember that. For that, you need to remember a mnemonic for IV cannulas, that is, Oh great God, please bless your people. Okay? When I am telling oh great God, please bless your people, oh great God. O means what? Orange IV cannula. Great means gray. Next is green. Next, pink. Bless, blue. Your is yellow and people is purple in color. Okay, these are the things. These are the IV cannulas colors. Okay, as we are remembering this mnemonic, you have to remember what cannulas are starting from what size? 14 gauge. After that, just add 2 gauge extra. 14, then gray will be 16, green will be 18, pink will be 20, blue will be 22, yellow will be 24, and purple will be 26. Okay, normally for pediatric cases, we are using yellow cannula. Okay, for pediatric cases. For neonates, we use this purple cannula, but normally for pediatric cases, we are using this. For normal surgical cases, we are using green and pink cannula. Now, guys, they are being asking you about the flow rates also. If at all someone asks you what is the flow rate of the IV cannulas, always remember from the bottom. It is very easy to remember, guys. Okay, when you are using a 26 gauge IV cannula, very small size, it will deliver fluid at a rate of 10 ml per minute. Then 24 is a double of it, 20 ml per minute. Then 22 is 30 ml per minute. 20 gauge is 50 ml per minute. 18 gauge is 100 ml per minute. 16 gauge is 200 ml per minute. Okay, whereas 14 gauge is 270 ml per minute. These are the different gauge size of IV cannula. This is the flow rates, okay, that we have to remember. Next question, guys. 45-year-old male with acute intestinal obstruction and vomiting is posted for emergency laparotomy. Yes, we have to keep add numbers, okay. He's alert, dehydrated and has not been fasted. During induction, which of the following is most appropriate airway management plan? So, okay guys, what we need to do over here. Patient is basically full stomach patient, posted for surgery, emergency surgery. Any emergency surgery or full stomach, when the patient is full stomach, he is at risk of aspiration. If you want to give general anesthesia in a patient who is at risk of aspiration, obviously you will go for what? You will go for RSI. What is RSI? Rapid sequence induction is called as RSI. Okay? So what's the answer over here, guys? What we need to do? We need to pre-oxygenate the patient, induce with propofol, give choline, remember, and apply cricoid pressure. Basically, this is the right answer, but it has to be framed in that. First, pre-oxygenate. Second, induce with propofol. Third, immediately after induction, apply cricoid pressure. Fourth, give succinylcholine, and then intubate without mask ventilation. Giving midazolam and intubating under deep sedation means he will be at risk of aspiration. Inducing with ketamine, yes, I can induce with ketamine, but again mask ventilation I cannot do, because mask ventilation when I do, again aspiration risk increases, so this cannot be done. Okay, mask ventilation again it is given, so this cannot be done. So cricoid pressure, putting pressure on the cricoid cartilage. Why do you put pressure on the cricoid cartilage, or what is it called as? It is called as Selleck's maneuver. It will close the esophagus. Okay, so who are the patients who are at risk of aspirations? Patients who are obese. Okay, pregnant ladies, basically person who's having high intragastric pressure, he will be at risk of aspiration. Obese patient, pregnant lady, GERD or hiatus hernia, or in case of any emergencies and all, right, they are at risk of aspiration. Sir, patient is not fasted, so how about ketamine? Yes, you can give ketamine to the patient. Ketamine preserves the airway reflexes, but again you cannot go for a mask ventilation. Mask ventilation is given in the option, so you cannot go for mask ventilation. Mask ventilation is always avoided. Okay, bag mask ventilation is always avoided, right? Next, so that technique is called as RSI. In RSI, we pre-oxygenate the patient with normal mask. What is avoided, guys? BMV is avoided. What is BMV? That is bag mask ventilation is avoided. Then immediately after IV induction, pressure is applied on the cricoid cartilage. What is that pressure called as? That pressure is called as Selleck's maneuver. Selleck's maneuver. Now, sometimes they might ask you, when do you remove the Selleck's maneuver? So, answer should be what? Once I intubate and inflate the cuff. Once I inflate the cuff, then only I am sealing the trachea, right? So, Selleck's maneuver is removed once I intubate and inflate the cuff. Then Selleck's maneuver can be removed. Okay. Coming to the next question. Patient was planned for surgery under general anesthesia. In the induction phase, rocuronium was given, but the anesthetist did not succeed in intubating. Hence, which should be the best reversal agent? Now, guys, this happens. Sometimes patient might have a difficult airway and this can happen. So, what's the answer that you have marked over here, guys? Neostigmine, physostigmine, atropine, sugammadex. First of all, remember guys, neostigmine can be given, but there is some better option than neostigmine. Why? Because remember, he's asking you about the reversal agent. In the reversal agents, we are having many reversal agents. The most commonly used is what? Neostigmine. But there is a newer reversal agent which belongs to modified gamma cyclodextrin, which is sugammadex, which is commonly used for rocuronium and vecuronium. Okay? What about physostigmine? Physostigmine is never used. It crosses blood-brain barrier. What about atropine? Atropine is never used for reversal, guys. Atropine is added to neostigmine in order to counteract the side effect of neostigmine. Side effect of neostigmine is what? Bradycardia. Okay, guys, reversal agents are what? Neostigmine, which is most commonly, but what will happen with neostigmine? Bradycardia can happen. So what you can give is either you add atropine to neostigmine or either glycopyrrolate. Okay, pyridostigmine, L-cysteine can be used, edrophonium can be used, and sugammadex is commonly used for rocuronium and vecuronium. If at all you are using this, you can use sugammadex. Okay, but how will you come to know, guys? Now I have to reverse the patient from anesthesia. Don't tell me, sir, that surgeon finishes the surgery. I'm not asking about that. I'm asking how will you come to know? Now, surgeon will finish the surgery. After that, how will you come to know? You will see some signs in the patient. You will tell the patient, if the patient is responding to your commands, you tell the patient to lift his head. If he is lifting his head for more than 5 seconds, that is the good sign that now you can reverse the patient. Or if you if you have train of 4, then you go for train of 4 ratio. If the train of 4 ratio is more than 0.9, then you have to reverse it. Okay, sustained head lift of more than 5 seconds. That is the best bedside sign. Or overall best clinical sign is what? Train of 4 ratio more than 0.9. Okay. Next, guys, which is the fastest acting inhalational agent among the following? Come on, guys, which is the fastest acting inhalational agent? Come on, who determines what is fastest and who determines what is most potent inhalational agent? Remember, guys, in inhalational agents, there are two things. One is called as MAC, other is called as blood gas coefficient. MAC indicates the potency of inhalational agent, whereas blood gas partition coefficient indicates the speed of onset and recovery. Speed of onset and recovery. Okay, right. Speed of onset and recovery. But always remember, guys, MAC and potency are always opposite. Meaning what? High MAC is equals to low potent. Low MAC is equals to high potent. I told you high MAC is equals to low potent and low MAC is equals to high potent. Leave the MAC. We are not discussing about MAC. Our question was, which is the fastest acting inhalational agent? Who determines the fast or slow? It is the blood gas coefficient. Again, blood gas coefficient also. High blood gas means slow onset. Low blood gas means fast onset. Now, guys, for that there is a mnemonic, guys. If you remember the mnemonic for MAC, the mnemonic for blood gas coefficient becomes very easily. Okay? The mnemonic for MAC is what, guys? HIST. Okay? Most potent to least potent. This is for the MAC. Okay? Most potent to least potent. HISD means what? Halothane, isoflurane, sevoflurane, desflurane. Okay? Most potent among these is halothane. Now, guys, is asking you about which is the fastest. Again, fastest has nothing to do with the MAC. But if you read this in the opposite direction, you will get the fastest acting. Opposite direction, usually it comes as DSIH. D stands for desflurane. S, sevoflurane. I, isoflurane. H, halothane. So which is the fastest among this? Fastest is what? Desflurane. Okay? And slowest among this is halothane. So now, guys, look over here. Look over here. Fastest acting, yes. If at all, remember, guys, HISD is a universal mnemonic. But to this, you can add M. M is what? Methoxyflurane. It is not commonly used, but you can remember methoxyflurane is the fastest acting among all. It is having a MAC value of 0.16 when compared to halothane, which has a MAC value of 0.75. Okay. As methoxy is not commonly used, we are using halothane. Okay. So the answer over here is what, guys? Desflurane is the fastest acting. Everyone got this right? Chalo. This capnograph detects what condition? First of all, guys, capnograph is nothing but you are measuring the exhaled carbon dioxide of the patient. That exhaled carbon dioxide is very useful for many of the conditions and all. Okay, right. Malignant hypothermia. Remember, in malignant hypothermia, the capnograph that you will see over in malignant hypothermia is something like this. Step ladder, it is increasing. So this is the malignant hypothermia. Gas embolism, that is not gas embolism. Gas embolism, capnograph. Usually gas embolism means venous air embolism. Okay? Slowly or gradually, or it is basically decreasing trend. Gas embolism. In case of soda lime exhaust, you will see what capnograph? You will see the capnograph value above the baseline. That is soda lime exhaust. Okay? What is this capnograph indicates, guys? This looks like what? This looks like a shark fin. So this is what, guys? This looks like a Shark fin. So this is shark fin capnography, which is indicative of what? Which is indicative of bronchospasm. In bronchospasm, you will see shark fin capnography. Okay. Now, guys, regarding capnograph, there have been many questions asked. This is the normal capnograph. There will be 4 phases in capnograph. First phase of capnograph, when the capnograph is starting like this, the first phase is called as inspiratory baseline. The second phase of capnograph, as it is going upward, it is called as expiratory upstroke. Okay? Then the third phase of capnograph, which is starting over here, it becomes what? Alveolar plateau. Alveolar plateau. Okay? And the last phase of capnograph is expiratory downstroke. Sorry, inspiratory downstroke, not expiratory, it is inspiratory downstroke. These are the 4 phases of capnograph. Now, what is the normal capnograph value, guys? Normal capnograph value is 35 to 45 mm of Hg, which is basically, remember, capnograph has many roles, guys. One of the best role of capnograph is what? If you intubate the patient, how will you confirm whether you are in the trachea or in the esophagus? Now, don't tell me, sir, auscultation. Yeah, auscultation can be done. It's a screening method and all. Okay? All those are screening methods. But if you are in the trachea, you connect it to capnograph and you see this capnograph coming, that means what? The patient is exhaling carbon dioxide. He exhales carbon dioxide when the tube is in trachea. Okay? So, normal value we have checked. Now, guys, different capnographs. If at all, after intubating the patient, if you get a flat line capnograph, what does it indicate? Flat line, yani ki you have done intubation and you get a flat line. It could be seen if you are in the esophagus. If you have done esophageal intubation, you might see flat line. Sometimes you might be in the trachea, you might get a flat line. Why? Patient might have collapsed after intubation. Yani ki in case of cardiac arrest, you might see a flat line. In case of complete bronchospasm, remember, normal bronchospasm, you will see shark fin. In complete bronchospasm, you will see what? A flat line. Or in case of accidental extubation, also you will see a flat line capnography. Shark fin pattern capnography, we have already discussed, that is seen in bronchospasm. Okay. If you see sudden fall of EtCO2, come on guys, sudden fall of EtCO2, it is seen in venous air embolism. Again, the murmur that you see over here is what? Mill-wheel murmur. Mill-wheel murmur. Okay. Next, Currar notch capnography. When do you see Currar notch capnography, guys? Just look over here. Currar notch capnography is seen. When do you see this notch developing? Normal capnograph should be without notch. When this notch is coming, that indicates there is return of spontaneous ventilation. There is return of spontaneous ventilation. What does it mean? During anesthesia, you give muscle relaxant to the patient. Patient muscles will be relaxed, but for some time only. After some time after 40 minutes. Usually duration of muscle relaxant is for 30-40 minutes. After 40 minutes, patient starts to breathe spontaneously. You will see Currar notch. That indicates what? What should be the next step, guys? If you see return of spontaneous ventilation, if the surgeon is telling more surgery is left, then the next step is what? You give muscle relaxant. You give top-up dose of muscle relaxant. Top-up dose of muscle relaxant. Okay. Next, if at all you have kept the patient on mechanical ventilator and you have increased the respiratory rate, what you will see in the capnography? You will see this capnograph. This capnograph means what? Hyperventilation, yani ki you are basically washing out the carbon dioxide. Hyperventilation, you will see this. In case of hypoventilation, where you decrease the respiratory rate, carbon dioxide gets accumulated and you will see this kind of capnograph. So these are the different capnograph values that you see over here. Okay. Next, guys. Least potent inhalational agent among the following. Come on, guys. Potent yani ki he is asking. Inhalational agent, potent yani ki he is asking you about MAC value. Okay. MAC, highest to least MAC, mnemonic is HISD. Come on, guys. Be fast. HISD, which is the least potent in HISD. The most potent is halothane. Least potent is desflurane. Okay. More bad than desflurane is what? Xenon and nitrous oxide. Xenon and nitrous oxide. Okay. Xenon having a MAC value of 70, nitrous having a MAC value of 105. Okay. So I have already told you, H stands for most potent to least potent, halothane, isoflurane, SIVO, and desflurane. Okay, next. During induction, a 50-year-old patient with rheumatoid arthritis develops cannot intubate, cannot ventilate kind of scenario. Now, this is a nightmare for any anesthetist. Cannot intubate, cannot ventilate. What you will do? Come on, guys. What you will do? In this scenario, what you will do? Cannot intubate, cannot ventilate. Immediate answer, एक ही जाएगा. Already he has. Basically, remember, guys. Normally, for any anticipated or unanticipated difficult airway, the algorithm which we follow is DAS guidelines. In the DAS guidelines, what is the first thing that we need to do is we need to go for laryngoscopy. Okay, plan A is what? You go for laryngoscopy and tracheal intubation. 3 best attempts while going for the first attempt. If you failed in the first attempt, you change the position, you change laryngoscope, you change the tube, okay, and then you try for the second attempt. Give 3 best attempts. If you fail, then you go for plan B. Plan B is what? If you're not able to intubate, your aim should be what? I should be ventilating the patient. Aim should be I should ventilate the patient. Ventilate the patient. Now, how will you ventilate the patient if you're not able to intubate? Put a LMA. LMA is what? Laryngeal mask airway, which is a supraglottic airway device. If at all after putting the LMA, normally 90% of the cases patient saturation improves, but still not improve, then you go for plan C. Plan C is what? Remove the LMA and go for 2% technique. 2% technique. If at all 2% technique is also failing, that is very rare, guys. 2% technique of ventilation means what? One will be holding the mask, one will be bagging and all. If that also fails, the last is what? Now you need to declare cannot intubate, cannot ventilate. You need to go for emergency cricothyrotomy, either needle or either surgical. Surgical is the best way, but needle it can be done. Needle cricothyrotomy can be done in the emergencies. So remember, cannot intubate, cannot ventilate scenario. The answer is what? Transtracheal jet ventilation or surgical cricothyrotomy. Other options you cannot do. Cannot intubate, cannot ventilate means third. Yani he's asking for plan D. What you should do. Okay. Now, guys, imagine you have done tracheostomy. Have you seen tracheostomy tube? Just look over here. Tracheostomy tube looks like this. This is a tracheostomy tube with a cuff. Okay. Now, when you are looking for the tracheostomy tube cuff, previously they has asked you about what is the pressure. What is the purpose of the cuff? Remember, cuff provides a seal for positive pressure ventilation. It provides a seal for positive pressure ventilation. It prevents aspiration. It prevents leakage. Leakage of air can be prevented by this cuff. Okay, not only tracheostomy tube, normal endotracheal tube also. And it stabilizes the tube. Okay, tube will be stable inside the trachea due to this cuff. This is the importance of cuff. Next, guys. Now we'll discuss something about normal intubation before going to the next question. Now, in normal intubation, guys, if at all you want to go for normal intubation, first thing you look for the position. Second is you look for the laryngoscope. Third is once you do the laryngoscope, you will be having what? You will be in front of you will be the vocal cords. Based on the appearance of vocal cord, there is a grading called as Cormack-Lehan grading. So first, guys, remember what is the position required for intubation for a normal person? It is the sniffing morning air posture. Sniffing morning air posture. In sniffing morning air posture, where is the flexion, guys? Very, very important. In sniffing morning air posture, the flexion is at the cervical spine, whereas the extension is at the atlanto-occipital joint. Atlanto-occipital joint. Okay? I'll tell. Okay? If at all the patient is normal, we use this position. If the patient is obese, we use rammed up position. For obese patient, we use rammed up position. So after giving the position to the patient, then we take the laryngoscope. There are 2 kinds of laryngoscope. One is called as what? One is called as Macintosh laryngoscope. Other is called as Miller's laryngoscope. Normally we use Miller's laryngoscope or straight blade laryngoscope for pediatric cases because they have a large epiglottis. Once you put the laryngoscope and lift the tongue, you will see what? Vocal cords. Based on the appearance of vocal cords, there is a classification which is called as Cormack-Lehan grading. Cormack-Lehan grading. Okay? In Cormack-Lehan grade 1, what do you see, guys? You will see whole laryngeal aperture. Cormack-Lehan grade 2 means what? You will see posterior wall of laryngeal aperture. ठीक है. Cormac 3 means what? Only epiglottis is visible. Cormac-Lehan 4 is what, guys? Cormac-Lehan 4 means epiglottis is also not visible. Okay, that's regarding the grading. Now guys, while intubating and all, sometimes you have to be clear for the anatomy, guys. Anatomy means what is the narrowest portion of the adult airway and narrowest portion for the pediatric airway. For adult guys, the narrowest portion is what? It is the glottic opening. It is a glottic opening. Whereas narrowest portion of the child's airway is subglottic. It is subglottis. Okay, sometimes some persons will be telling dono same hai ya dono alag hai, but both are different. Okay, now guys, a patient under anesthesia develops unexplained jaundice and elevated liver enzymes 1 week after exposure to a volatile anesthetic. Volatile means he's asking about inhalational agent. Which drug is most likely responsible? If a person develops jaundice, it is basically immune related jaundice that usually happens due to repeated exposure or due to overexposure of halothane. No other will cause any liver problems except halothane. Now guys, if at all you are giving halothane, always remember that halothane starts with the alphabet H and you have to remember 4 H's of halothane. Okay? First H of halothane is what? Halothane is contraindicated in heart disease. Why halothane is contraindicated in heart disease? Due to 2 reasons. One reason is it causes hypo and bradycardia together, as well as it sensitizes the heart towards catecholamine that leads to arrhythmias. So halothane is contraindicated, okay, for heart disease. Second H stands for what? Hepatitis. Hepatitis means what? On repeated exposure of halothane or overexposure, patient might develop a immune-related hepatitis, which is called as halothane-induced hepatitis. Third H is what? Hyperthermia. Hyperthermia, when we are talking about what hyperthermia? Malignant hyperthermia. In anesthesia, many things can cause malignant hyperthermia, but inhalational agents almost all will cause, but the maximum incidence of malignant hyperthermia is seen with halothane. Next, halothane has 2 maximums. What 2 maximums? Maximum bronchodilation and maximum muscle relaxation. Bronchodilation and maximum muscle relaxation. Now don't confuse yourself, guys. Muscle relaxants are different. Halothane is different. Halothane is basically used to maintain the patient unconscious. But additional point is what? It will cause some muscle relaxation also. That's why usually halothane, if you are giving general anesthesia for cesarean section, halothane you are avoiding. Why? Because it will cause muscle relaxation and can cause PPH also. Okay. Next, in which condition LMA insertion is contraindicated? Come on, guys. LMA is what? Laryngeal mask airway. When we are talking about laryngeal mask airway, first of all, it is a definitive airway or non-definitive airway? It's a non-definitive airway or a temporary airway. Okay? In which condition it is contraindicated? If there is any blood in the oral cavity or any tumor in the oral cavity, you cannot put the LMA. If there is blood, you are pushing that blood into the trachea as well as the lungs. So blood in the oral cavity. Rest all are the indications. Short duration surgery, you use it. Pediatric surgery, you use it. Difficult airway, if at all you are not able to intubate, second step is what? You put an LMA. But going for LMA, is it a definitive airway? It's never a definitive airway. There are 2 categories of LMAs, guys. Okay? First generation and second generation. Third generation is also there. First generation. First generation is what, guys? LMA which is having only a single port. That is examples are classical LMA, flexometallic LMA, Cobra LMA and Ambu Aura 40. All are having single ports. Okay? But remember, LMA is a non-definitive airway. Why? Because it poses the patient to at a risk of developing aspiration. Okay, second generation LMA, when do you call? When you add an extra port to this LMA, yani ke this extra additional port through which you can put the Ryle's tube and deflate the stomach. Examples are LMA Proseal, LMA Supreme, iGel, okay, Ambu Gain is there and Slipa is there, streamliner of pharynx. Okay, these are first and second generation LMAs. Next, 40-year-old COPD patient, conscious, coherent, having respiratory distress, is receiving oxygen through high flow nasal cannula, but still saturation not improving. What's the next step? If at all he was not asking you this, okay, Imagine this patient just came to the casualty with low saturation. The first thing that you apply, the first airway device that you keep is what? Is nasal cannula. Okay? Nasal cannula. If nasal cannula is not working, then face mask. If still after face mask patient saturation is still not improving, then we tell the sister to apply NRBM. What is NRBM? Non-rebreathing mask. If after non-breathing mask also patient saturation is not improving, Venturi mask. If after Venturi mask is also not improving, high flow nasal cannula you have to give. But over here in our question, high flow nasal cannula, yani ki all other masks were applied. Now they were giving high flow nasal cannula, still not improving. What's the next step? You need to go for ventilation. A ventilation, are you going for invasive or non-invasive over here? Patient is conscious, coherent, so you can go for NIV, that is non-invasive ventilation. Non-invasive ventilation. Now guys, remember, non-invasive ventilation can be given for which patient? Very, very important. NIV, there are two modes in NIV, BiPAP and CPAP, but these are used for patients who are conscious and coherent. Conscious, coherent, as well as patient should be empty stomach. If the patient is full stomach and you put an NIV mask, then what will happen? And he is drowsy, he will aspirate. So vital prerequisite is what, guys? Conscious, coherent, and empty stomach. And there are two modes in NIV. One is CPAP, other is BiPAP. CPAP is continuous positive airway pressure, that is usually given for mild to moderate kind of COPDs. Whereas if at all the patient is not improving, the best mode for non-invasive is BiPAP. In BiPAP, there are two modes, guys. In BiPAP, there is inspiratory and expiratory, where we give high inspiratory pressure and low expiratory pressure. It is used for severe COPD. But remember, guys, BiPAP is contraindicated if the patient is drowsy or full stomach. Okay, nitrous oxide, when we are discussing, we have to discuss some things about nitrous oxide. What is the MAC value of nitrous oxide? 105. Yani it is having a high MAC value. Any agent which is having a high MAC value will be the least potent. Due to this reason, we don't use nitrous as a normal gas. We use nitrous with some other inhalational agent as a supporting gas. So it is also called as used as a carrier gas. What is the cylinder under which nitrous oxide is stored, guys? Nitrous starts with N. Neela. Hamesha you have to remember nitrous as Neela. Neela means blue. Nitrous is always stored in what color cylinders? Blue color cylinders. Nitrous is a very good analgesic, but it is avoided in what? Closed loop surgeries as well as cardiac surgeries. Why? Because in cardiac surgery, it is increasing the pulmonary vascular resistance. Why in closed loop surgery, nitrous is avoided, guys? If you give nitrous in a closed loop, it will expand the air containing cavities. So nitrous is avoided. What two things you will see with nitrous? You will see diffusion hypoxia, and you will also see second gas effect. Just a second, guys. Right, diffusion hypoxia and second gas effect. So diffusion hypoxia, what do you see? Remember, as nitrous is having a heavy weight, it displaces the oxygen outside the alveoli. So at the end of surgery, while you are cutting down the nitrous, give 100% of oxygen, 100% of oxygen for 5 minutes to prevent this diffusion hypoxia. One is called a second gas effect. Second gas effect means what? If you give nitrous with some other inhalational agent, it will increase the concentration of that inhalational agent. Concentration of other inhalational agent will be increased with nitrous. That is called a second gas effect. Okay. Perindic system of nitrous, again, you guys know it. It is 3-5. Okay. We'll discuss later. 6-year-old child is undergoing tonsillectomy. You plan to give him general anesthesia, but the child is not allowing you to put an IV line. Hence, you decide for inhalational induction. Normally, guys, induction yani ki you make the patient unconscious. That is induction. Normally, for making the patient unconscious or for induction, we use IV. Okay? But IV is not possible. Then you use inhalational. Okay? Rarely inhalational. But in inhalational, which is the inhalational agent which is used in children, it is a sweet odor, yellow colored Sevilla sevoflurane. Sweet Sevenya you have to remember. Sivo is Sevenya. Sevenya means it will be sweet as well as yellow in color. Why you have to remember yellow in color? Why? Because sevoflurane is stored in yellow vaporizer. Now, as we are discussing about sevoflurane, we need to discuss some things. Sevoflurane is a special inhalational agent which is used for induction as well as maintenance purpose. Rest all inhalational agents are used for maintenance. Sevo is used for induction as well as maintenance purpose. It is the inhalational agent of choice for bronchial asthma. Why? Because it causes good amount of bronchodilation. When compared to halothane, it causes less airway resistance. Hence, it is the best inhalational agent for bronchial asthma. Okay. Next, it is an inhalational agent of choice for children. Why? Because it's having what odor? It's having a pleasant odor. Next is, it is an inhalational agent of choice for daycare surgery as well as neurosurgery. Now guys, remember daycare surgery, previously we used to tell desflurane is best. But nowadays it is what guys? It is sevoflurane, the best inhalational agent of choice for daycare surgery. Why? Because desflurane is causing airway irritation. Okay. But sevoflurane should be avoided in renal patients. Why? Because sevoflurane can react, if at all you are using sevoflurane in closed circuit, that too in low flows, it reacts with soda lime to form a compound called as compound A or olefin, which is a nephrotoxic compound. Okay. Next guys, regarding isoflurane. Remember isoflurane, what we need to remember, it's the most common agent used in cardiac surgery, safe in renal surgery, but isoflurane has having a side effect of coronary steal phenomena. Yeah, now you must be thinking, if iso is having coronary steal phenomena as a side effect, why are we using it in cardiac problems? Why? Because in animal studies only it has been proved that isoflurane causes coronary steal phenomena. Next guys, what is the control variable in the volume control mode of ventilator? Come on. In the volume control, which is a control variable. Control variable means what you are controlling on the ventilator. You set on the ventilator, then it will take care of other things. What is that mode? Control variable is, come on, the control variable in volume control mode is the tidal volume. You set the tidal volume and then that's a control variable. The variable that you are controlling, not the ventilator, is control variable. Okay. So, but remember guys, there is one mode of ventilator that controls the tidal volume as well as the pressure. Okay? In pressure control mode, the control variable is pressure. Whereas in volume control mode, the control variable is tidal volume. There is one mode of ventilator that controls the volume as well as pressure. What is that mode called as? Come on guys, what is that mode called as? That mode is usually what? That mode usually thinks that kabhi lagta hai apuni bhagwan hai. Why? Because it is controlling the volume as well as it is controlling the pressure. That mode is called as CMV mode. Okay? Continuous mandatory ventilation. So regarding just a brief thing regarding the ventilators guys. Okay? Even though for FMGE they are not asking much, but still you have to remember. In CMV mode, what is the control variable? It is tidal volume as well as pressure that is under control of ventilator. Okay? Trigger breathing. Remember, in CMV mode, ventilator is controlling all the things. He will tell to the doctor, I am controlling all the things. Your patient should not be moving at all. No triggered breathing is allowed. And the ventilator will also tell you that patient should be sedated heavily. Why patient should be heavily sedated? Why? Because the ventilator is totally controlling all the things. Patient should be heavily sedated. But as the patient is heavily sedated, patient also feels relaxed and patient will think that, okay, now I am relaxed. Ventilator is taking care of my breaths. He becomes lazy. Due to that thing, what will happen to his muscles, respiratory muscles? Muscles also becomes lazy. There will be atrophy of muscles in CMV mode. Okay? In CMV mode. Okay? Next is what guys? ACMV. ACMV यानी कि if the patient is improving on CMV or if the patient is basically if you want to de-escalate the patient from ventilator from CMV, you can go for ACMV. In ACMV, there are two modes, volume control and pressure control. In volume control, what is the control variable guys? It is the tidal volume. Whereas in pressure control, what is the control variable? It is the pressure. Trigger breathing, yes. Yes, trigger breathing is allowed. Sedation, you will be requiring moderate sedation in both the modes. ठीक है. And sometimes depending upon the patient lung mechanics, patient might have hypoventilation or sometimes hyperventilation also, that can lead to acidosis or alkalosis too. ठीक है. But if the patient is improving on ACMB mode, then we tell the patient, यानी कि now we are telling that we can remove the patient from ventilator, but before removing it, we keep the patient on spontaneous mode. In spontaneous, there are two modes, SIMV and pressure support mode. ठीक है. In SIMV mode, trigger breathing is, yes, trigger breathing is allowed. Mild sedation might be required or no sedation is required. Mild to no sedation might be required. Okay. So in SIMV mode, basically just look over here, guys. Ventilator is generating one breath and then you are allowing the patient to take one breath. Okay. But ventilator tidal volumes are reaching this level. Patient tidal volumes are reaching this level. Due to this, there will be asynchronous. Sometimes there might be chance of hypoventilation also. Hypoventilation. Okay. In spontaneous modes, you will see this. Okay. Next, during central line insertion, patient develops sudden breathlessness, hypotension, tracheal shift to the left, absence of breath sounds on the right, and what could be the best immediate step? Come on, guys. ABCD, what's the answer over here? Now, guys, remember what has happened basically during central line. Central line means, did I tell you IJV? Did I tell you subclavian? Did I tell you femoral? No. But you assume what? IJV only. Why? Because it is the most common site for insertion. And after IJV insertion, the patient is developing breathlessness, hypotension, tracheal shift. All these are features of what? Patient has developed pneumothorax. If the patient has developed pneumothorax, what should be done? Will you go for chest x-ray? No, sir. Why should I waste time on chest x-ray when the patient is giving you all clinical signs? Okay? Apart from these clinical signs, the patient's airway pressures are also high. Airway pressure is also high. Okay? So you don't go for chest x-ray. Will you go for re-intubation? Will you go for intubation for this patient? No, bhai. If you go for intubation, you will increase the intrathoracic pressure and all. And again, pneumothorax will worse. IV fluids, yes, can be given, but again, IV fluids, if you give IV fluids, treat pneumothorax? No. The best way is what? Best way is needle decompression. Okay? Best way is what, guys? Needle decompression. Now, when you are going for needle decompression, where you are going, guys? Remember, the classical way for needle decompression is you choose for the second intercostal space and you choose the mid-clavicular line. Mid-clavicular line. Second intercostal space, mid-clavicular line. Or you can go for fifth intercostal space, mid-axillary line. ठीक है भाई. नीडल डिकम्प्रेशन क्यों? न्यूमोथोरैक्स, टेंशन न्यूमोथोरैक्स हो सकता है ना, ट्रेकियल शिफ्ट टू द अदर साइड. दिस थिंग्स आर द फीचर्स ऑफ न्यूमोथोरैक्स. यू हैव टू गो फॉर नीडल डिकम्प्रेशन. ठीक है. बेस्ट मैनेजमेंट इज thoracostomy, but you have to go for it. Best management for pneumothorax is thoracostomy. Right? Now, regarding central line insertion, guys, I told you in the question there was no mention of which central line was placed. Central line is basically a catheter which can be kept into the larger veins, larger blood vessels. You can choose internal jugular vein, which is the most preferred site. You can choose subclavian vein, guys. Subclavian, if you choose subclavian, there is least chances of infection. Okay? Or you can choose femoral, where there are more chances of infection. Chest x-ray, where it is done, you are telling. By chest x-ray, again, remember, if you are clear that this patient is having all these features are there, means he is having pneumothorax. Why you need to waste time on chest x-ray? Sometimes what happens if pneumothorax develops into tension pneumothorax and all, you won't have the time, patient will collapse, cardiac arrest will happen. Okay? So in that case, you have to be always ready. Clinical features you have seen, okay, done. You have to go for needle decompression. It is showing central line insertion ke baad mein this patient is developing these features. Okay. Next, a young male in trauma has hypotension and tachycardia. Which induction agent is best, guys? Now remember, guys, he's asking you about IV induction agents. Now remember, IV induction agents are the agents that are used to make the patient unconscious. Okay, make the patient unconscious. Okay, in IV induction, you are having two types of IV induction. One is called as opioid induction, other is called as non-opioid induction. Remember guys, commonly we are using non-opioid induction. In opioid induction, when do you go? Opioid induction is given for patient who is having a low ejection fraction. Non-opioid means you are having thiopentone, propofol, ethambutol, ketamine. Thiopropofol, ethambutol usually makes the patient unconscious by acting on GABA receptors, whereas our hero ketamine usually works through the NMDA receptors and makes the patient unconscious. Apart from ketamine, what are the other things that works on NMDA receptors? Xenon as well as nitrous oxide. Okay. Now guys, the question was what? Which is the best IV induction agent when a patient is having hypotension and tachycardia? And a patient is in shock. Patient is having 70/40 BP. Which is the best one? If I give propofol to this patient, BP 70/40, BP becomes 50/20, or patient might develop collapse. If I give thiopentone to the patient, what will happen guys? Remember, propofol was causing hypo and bradycardia. Thiopentone will cause what? Thiopentone will cause hypotension as well as tachycardia. So BP will again fall to 50/20 and tachycardia will worsen. So this cannot be given, this cannot be given. How about ethambutol? If you give ethambutol, the BP previously it was 70/40. After giving ethambutol, it is 70/40. Is it doing good to the patient? No. Is it harming the patient? No. It can be given, but it is not doing any good. When we are having our hero ketamine, what will it do? Ketamine, when you give to the patient, it will basically make the BP 110/70 because ketamine increases the BP, but on the other side, it also increases the heart rate. So answer is what guys? Ketamine. Now, as we are discussing ketamine, a few points of ketamine we need to discuss guys. What are the few points of ketamine? Yes. Okay, we'll discuss about that later. Okay, ketamine is a complete anesthetic agent. It is a phencyclidine derivative and NMDA receptor blocker. Phencyclidine. Now, regarding ketamine guys, the most important thing is what is the effect of ketamine on various systems. Remember guys, ketamine does kit with the CNS and it is friend of all other systems. Okay, when I am telling ketamine gives a pat se headshot to the CNS. When patient takes ketamine, it will give a pat se headshot. Why? Because remember, ketamine, what does it do to the CNS? It's an enemy of CNS. So it increases the ICP. Hence, it is contraindicated in head injury. Not only increases the ICP, it increases the intraocular pressure. Hence, contraindicated in glaucoma. It is causing epilepsy. Hence, contraindicated in epileptic patients. Ketamine, as we give to the patient will have hallucinations. Patient will tell that after receiving ketamine, doctor, I am having this kind of feeling. After recovering from the effect of ketamine, patient will be telling, doctor, I was flying. Doctor, I was in some other world. Okay? So ketamine, as it causes hallucination, ketamine will be contraindicated in schizophrenia. Okay, if at all hallucinations are caused by ketamine, then the best management that could be given is what guys? You can give the patient midazolam. Okay, that's regarding what guys? That's regarding ketamine effect on this systems. On C, remember it does kit with the CNS, whereas ketamine is a friend of all other systems. What are all other systems? Respiratory, cardiovascular, muscle. That you have to remember. Ketamine is the best friend of all systems. Enemy of this. If you remember this one line guys, all MCQs will be solved. Okay, best friend of other systems means what? It is respiratory best. It's regarded as the best agent. That means what? It causes bronchodilation. Hence, it is the IV induction agent of choice for bronchial asthma. Okay. Next, ketamine acts on the myocardium. Ketamine, what does it do to the cardiovascular system? It increases the BP as well as pulse rate. Hence, it is the IV induction agent of choice. IV induction agent of choice in shock. Once again, I'm just reopening the app. Okay. Next, ketamine acts on the muscle by increasing the muscle tone. But remember, ketamine can be given for cardiovascular. You have to remember ketamine can be given for cyanotic heart diseases. Contraindicated in ischemic heart disease. You cannot give ketamine in ischemic heart disease. Why? Because in ischemic heart disease, you don't want patient's blood pressure to be on a higher side. Okay. That's regarding ketamine. Next, guys. Next, this question. Yeah, analgesic effect. Ketamine is the only analgesic, like any only IV induction agent that is having a good analgesic effect. Okay. Now, a patient is on ventilator. His PaCO2 kitna hai? 65. Our target PaCO2 is 35. What ventilator adjustment you have to do? Come on, guys. If at all you need to adjust the PaCO2 or wash out carbon dioxide from the patient, you need to just increase the respiratory rate. Increasing the FiO2 won't decreases PaCO2. Increasing the PEEP also will improve oxygenation, not his PaCO2. PaCO2 might be slightly improved by increasing PEEP, but increasing respiratory rate means what? You are letting out the carbon dioxide go out. Okay? If you decrease the respiratory rate, PaCO2 will increase only. So this is the right answer. But before going to it, remember guys, before going to the next thing, you have to remember some of the respiratory parameters and something about PEEP also, guys. Now guys, regarding respiratory parameters on the mechanical ventilator, what is the normal respiratory rate that you set into the mechanical ventilator? 12 to 18. If the question said oxygen, if the question said if you want to improve the oxygen, then you have to give PEEP, guys. Okay, so just look over here. Respiratory rate normally is 12 to 18, but if the patient is having respiratory acidosis, in that condition you increase the respiratory rate. Okay, what is the normal tidal volume, guys? 6 to 8 ml per kg body weight. But in the case of ARDS, where the lungs are in a very bad state, you cannot give much tidal volume. You have to always use 4 to 6 ml per kg in case of ARDS. That is low tidal volume. Low tidal volume. Next, FiO2 is 21 to 100%. Okay, that you keep. PEEP is how much, guys? 5 to 8, but you can keep PEEP up till 24 also. And the PEEP values depends on the FiO2 that you are using. Okay. Next, P plateau pressure is less than 25, and you have to set an I is to E ratio. I is nothing but inspiratory to expiratory ratio. Normally 1 is to 2, 1 inspiration is to 2 expiration, or 1 is to 3 expiration you give. But in case of ARDS, you will give a reverse or inverse ratio ventilation. That is what, guys? 3 is to 1 or 2 is to 1. 3 inspiration to 1 expiration you are keeping. And in ARDS, you can also go for prone position ventilation, keeping 16 hours patient in the prone position and then 4 hours of normal supine ventilation. Okay, that's regarding, guys. In order to increase PEEP, increase the FiO2. No. If at all you are keeping a high FiO2, then you have to increase the PEEP also. Okay, PEEP can be adjusted according to the FiO2 levels. Now, guys, what is this PEEP? First, we'll discuss something about PEEP so that you can understand. PEEP is nothing but positive end expiratory pressure. Now imagine, guys, in ARDS, where the alveoli are in a very bad state, all alveoli are being collapsed and all, they're not working. What does PEEP do? When you add PEEP, it will recruit new alveoli. It recruits the new alveoli that helps to improve oxygenation. Okay, so it is recruiting new alveoli to improve oxygenation. As new alveoli are being formed, it prevents atelectasis of older alveoli also. This PEEP will prevent atelectasis of older alveoli. But remember, guys, as you are increasing the PEEP, it will have some negative effect. What negative effect, guys? It will increase the intrathoracic pressure, that will decrease the cardiac output, hence leading to hypotension. Due to this reason, if the patient is in shock, we don't give PEEP. Okay? And one more thing for PEEP is what? When you are giving PEEP to the patient, what will happen? The cerebral venous drainage decreases. When you increase the PEEP, cerebral venous drainage decreases. Due to that, what happens? The intracranial pressure increases. So basically, PEEP is contraindicated in two conditions: shock-like condition, as well as if the patient is having a high intracranial pressure, you never give PEEP. Okay? PEEP improves oxygenation, prevents atelectasis, okay, and decreases the work of breathing. It is used for ARDS patient as well as pulmonary edema. Side effect of PEEP, I have already told you. It causes hypotension, as hence contraindicated shock as well as head injury. Why head injury? Why? Because remember, guys, I told you it decreases the cerebral venous drainage, hence leading to the increase in ICP. That is regarding what, guys? That's regarding the positive and expiratory pressure. Come on, guys. Next question. During general anesthesia, an intern accidentally connects a brown cylinder instead of white shoulder black cylinder to the yoke. Okay? The patient develops desaturation shortly after induction. What was the cylinder commonly used? Yani ke he connected a brown cylinder. What is the brown cylinder? First of all, he had to connect black body, white shoulder, that is oxygen. But that oxygen cylinder he does not connect. So brown cylinder is what? Remember, guys, nitrous is what? Nitrous is not a brown cylinder. It is Neela. So it is a blue cylinder. Carbon dioxide is what, guys? Carbon dioxide is gray color cylinder. Okay, air cylinder is what, guys? Black body, white shoulder. White body, black shoulders. Okay, in some countries you will find air cylinder as gray body and black and white shoulders. Helium cylinder is brown in color. Now, guys, remember in the anesthesia machine there is a component called as cylinders, and all cylinders are given color coding just to prevent what? Just to prevent the mishaps. Yani ke basically by looking at the cylinder color you can say this gas is there in the cylinder. Now, guys, remember this is the anesthesia machine that we are talking about. This is the Boyle's machine. In that we are talking about cylinders. What is the cylinder made up of? The most common material is molybdenum. Most common material is what, guys? Molybdenum. And these molybdenum cylinders are non-MRI compatible. They are MRI compatible cylinders which are made up of two materials. What two materials? Aluminium and titanium. These are MRI compatible cylinders. There are different sizes cylinders available. Size A till size J. Size A is the smallest cylinder. Size J is the largest cylinder, and most commonly we use size E cylinder. Okay, now coming to the color coding, one of the cylinders looks like this. Black body, white shoulder coupling. What is the cylinder? Basically, this is the picture of bodyguard, guys. Bodyguard is basically wearing a black dress with white shoulder coupling. And the bodyguard to us during anesthesia is nothing but oxygen. Oxygen cylinder is what? It is black body and white shoulders. So remember, color coding of the cylinders are what, guys? You have to remember. Oxygen, what is the color coding? It is the black body, white shoulder. White shoulder. Okay. Air, what is the cylinder color, guys? Air cylinder color is opposite of oxygen. That is white body and black shoulder. In some countries it is basically gray body and black and white shoulders. Nitrous, what is the color? Nitrous, it is Neela, yani ke I won't write also. Okay, blue color. Antonox is what? It is a mixture of mixture of oxygen and nitrous. That is blue body, white shoulder. Whereas carbon dioxide, what's the color, guys? It is gray color cylinder. Carbon dioxide is used for for laparoscopic insufflation of the gas, carbon dioxide. Okay. Now, guys, if someone is asking you what is the color coding of the pipeline, pipeline means what? It is very simple. If someone asks you color coding of the pipeline, take the shoulder colors of the cylinders and post it over here. It becomes the same. So what is the shoulder color of oxygen, guys? White. So oxygen pipeline color is white color. Air pipeline is black color. Nitrous pipeline is what? Body and shoulder both are Neela only. So it will be blue color. Then vacuum pipeline, guys, vacuum is for suction. Vacuum, remember, vacuum starts with V, but if you add a stroke, it becomes Y. So vacuum is yellow in color. Vacuum cylinder is yellow. Vacuum pipeline is yellow in color. Next, guys, a 30-year-old patient is posted for lipoma excision on the hand under general anesthesia in a daycare setup. Anesthetist plans to give TIVA, total intravenous anesthesia. Okay? Two clues are given: daycare, TIVA, which is the IV induction agent of choice. This, I guess, no one should get wrong. Very good. Propofol. Remember, guys, propofol is what? Propofol is a milky white solution which is made up of egg lecithin, glycerol, and soy. The egg lecithin present in the propofol acts as an emulsifying agent. Apart from that, what else you need to remember? Propofol should be used within 6 hours, otherwise bacterial contamination can happen, and it is the most painful IV induction agent. After propofol, ethambutol and thiopentone will come. But remember, propofol we are discussing. Propofol, when the question is asking you about daycare anesthesia and TIVA, and in the option it is propofol, answer is always propofol. Why? Because propofol is the IV induction agent of choice for daycare surgery. Daycare surgery. Guys, remember, when a patient is posted for daycare surgery, I won't put an ET tube. I will put an LMA. Hence, propofol is an IV induction agent of choice for LMA insertion. When a patient is posted for daycare surgery, I try to give TIVA to the patient, total intravenous anesthesia. Yani ke IV anesthesia, general anesthesia given without inhalational agent is TIVA. So I give TIVA. So IV induction agent of choice for TIVA is propofol. Next, when a patient is posted for daycare, all are related to daycare, guys. When a patient is posted for daycare surgery, I want to give a drug that is having anti-emetic property as well as antipruritic property. Both are seen with what? Propofol. Okay? Next, when a patient is posted for daycare surgery, I want my drug that can be safely given in malignant hyperthermia. I want my drug that has no problem with the liver. Yani it can be safely given in liver disorders also. Or I want my drug to be given to the patient which does not cause acute intermittent porphyria. So remember, guys, propofol fits in all this. It is IV induction agent of choice for not only daycare surgery, it is IV induction agent of choice for all these things which I have mentioned over here: malignant hyperthermia, liver disorders, acute intermittent porphyria. So you have to remember this regarding propofol. Next, 65-year-old patient is COPD patient is being ventilated through Mapleson circuit. Which circuit is most effective for spontaneous ventilation? Come on, guys. A, B, C, D. What's the answer? Mapleson A, B, C, D. Very good, very good, very good. Spontaneous ventilation, Mapleson A. Remember, guys, regarding Mapleson circuit, okay? Always remember mnemonic S, A, CD. SA, CD. What does it mean, guys? Mappleson's means you have to remember SACD. SA means what? Spontaneous ventilation A. Controlled ventilation D. Okay, SACD. Controlled ventilation D. So remember Mapleson. As the question was asking, spontaneous circuit of choice for spontaneous ventilation, Mapleson A circuit, also called as Maggle circuit. Why? Because it was modified by Maggles. It is a circuit of choice for spontaneous ventilation. Okay? When you are giving the fresh gas, it should be equal to the minute volume. Next, Mapleson D circuit, also called as what circuit? Also called as Baines circuit. Okay? Baines circuit. This is the circuit of choice for controlled ventilation. Here the fresh gas flow, in order to avoid rebreathing, fresh gas flow should be equal to 1.6 times the minute volume. Mapleson E is also there, which is also called as ISTPs. ISTPs is basically used for weaning of the patient of the mechanical ventilator. You use it, or moving the patient from one unit to other unit, you can use this ISTPs. Mapleson F, this is very important, guys. This is a modification of ISTPs, which is called as Jackson-Rees modification. This is a circuit of choice for controlled as well as spontaneous ventilation in pediatrics. Okay, remember, guys, bagless and valveless circuit is ISTPs. Okay, valveless circuit is Mapleson F circuit. Okay, Mapleson F means you will be having a bag, but it will be valveless. But now, guys, this was regarding the semi-closed circuit. If you are not using semi-closed circuit, you might use closed circuit for anesthesia. If you are using a closed circuit, there is no expiratory valve in closed circuit. So where will the exhaled carbon dioxide go? Exhaled carbon dioxide goes into a chamber where it is getting absorbed with the help of this. What is this called as, guys? This is called as soda lime. This is called as what, guys? Soda lime. So remember, soda lime is made up of what? 80% of soda lime. In closed circuit, you will see soda lime. 80% it is made up of calcium hydroxide, a major component. 16% water. 3% sodium hydroxide, which is a main component. Even though the major component is what? Calcium hydroxide, but the main component is sodium hydroxide. And 1 to 2% is made up of silica plus potassium hydroxide. Silica is added to make the granules hard. But remember guys, when you are using this closed circuit or soda lime, 3 inhalational agents should be avoided. I used to remember CT scan is avoided with soda lime. CT scan means what guys? C stands for reacts with soda lime to produce phosgene and dichloroacetylene that can cause ARDS. Sevoflurane is avoided with soda lime. It can form compound A. Okay. Next, this is regarding soda lime. If you don't have soda lime, the other thing that you can use instead of soda lime is barrelime. That is also a carbon dioxide absorbing material. But agents that are avoided with barrelime is what? If you use that agents with barrelime, patient might die. So DIE. D stands for desflurane, I stands for isoflurane, E stands for N-fluorane. If you give, they will react with barrelime to form carbon monoxide, and maximum carbon monoxide is formed with desflurane. It's just formed with desflurane. Okay. Next guys. 75-year-old patient collapses in the ward. He is unresponsive, apneic and has no pulse. What is the next best step in management? Come on guys. He has collapsed in the ward. What's the answer for it? Give 2 rescue breaths immediately. No. What should be the answer for it? Basically guys, remember, if any person collapses, leave this question. If any person collapses in front of you, the first thing is scene safety. Second thing, if the scene is safe, second thing is what? You check for the response. If not responding, third, you call for help. After calling for help, you check for the pulse as well as breathing. Pulse by carotid pulse and breathing looking at the patient's chest. No pulse, no breathing, you start your compressions. Over here, he's already told no response, no breathing, no pulse. Immediate answer should be what? Start high quality chest compression. That should be the immediate answer, guys. Is this thing clear? So we'll just discuss some points about the basic life support, guys. So remember, I told you the first step in basic life support is always remember the sequence is SCCS. S is what? Scene safety. C is what? Check for the response. C is what? Call for help. After calling for help, next is what? You check for the breathing and pulse. Which pulse you will check for, guys? You check for the carotid pulse in adults, whereas in infants you are checking for the brachial pulsations. Okay? Next, if no pulse, no breathing, you start your high quality chest compressions. Okay? Now remember guys, in high quality chest compressions, will you go for ABCD, or in BLS sequence, will you go for ABCD or CABD? CABD you are going for. C stands for what? C stands for compressions, high quality compressions. A stands for in the CPR. It is a step of CPR, guys. Okay? A stands for airway, B stands for breathing, and D stands for defib. All these are integral parts of CPR. Compression, airway, breathing, and defibrillator. Now we are discussing about what? Check rhythm with defibrillator and all. No. Yeah, patient cardiac arrest, no pulse, no breathing. Start. Okay? Start compressions. Next, when you are giving chest compressions, guys, just look over here. What is the number of chest compressions? Number is 100 to 120 compressions per minute. What is the depth of chest compression? 5 to 6 centimeters or 2 to 2.4 inches of depth. In case of adults. In case of infants, 1.5 inches or 4 centimeters. Okay. Next, in case of more than 1 year old child, then you have to go for 2 inches or 5 centimeters. That should be the depth. In case of more than 1 year, you can also go for the chest compression depth is 1/3 of the anterior posterior diameter. Now what is the ratio, guys? Ratio is 30:2. It doesn't mean that in 1 minute 30:2. In 1 minute 100 to 120. That means in 1 minute 4 sets of 30:2 has to be given. 4 sets. But remember, you have to allow a good chest recoil also. Now we'll discuss something about CPR later in the next questions. Next is what? A 60-year-old male patient with ischemic heart disease is scheduled for hernia repair. Which IV induction agent is safest? Come on guys, what's the answer for this? Ischemic heart disease patient. Ischemic heart disease patient, always remember, these patients cannot tolerate any changes, extreme changes of the blood pressure. Whether hypo or whether hyper, they cannot tolerate. Neither tachycardia, neither bradycardia they can tolerate. So remember, propofol, what will it do? It will cause hypotension and bradycardia. Thiopentone will cause hypotension and tachycardia. Ketamine will cause hypertension and tachycardia. So this cannot be given. Okay? The one that will maintain their heart rate and all this, ethomidate. So an IV induction agent, ethomidate is also an IV induction agent, which is the most cardio-stable IV induction agent. It is the most cardio-stable IV induction agent, but it comes with a side effect. When you give ethomidate as a long-term infusion, patient will have what? Patient will have adrenal suppression. Very, very important. Adrenal suppression. Okay, there is one more IV induction agent which is called as methotrexate. This is commonly used for patient posted for electroconvulsive therapies. Okay, next, during basic life support in a single rescuer scenario for 6-year-old child, the correct compression to ventilation ratio is 30:2. But if the question was saying more than one rescuer, then the answer should be what? More than one rescuer means you have to go for 15:2. Okay, but single rescuer, it is always 30:2. So compression to ventilation ratio we'll discuss. In case of single rescuer, in case of adults, it is always 30:2. In pediatrics, in case of single rescuer, 30:2 is the ratio. Whereas if there is more than one rescuer in adults, always 30:2 only. But in pediatrics, 15:2. Why? Because pediatrics children are having a higher respiratory rate. And during the CPR and all, if you have placed an advanced airway, then how will you give the breaths? Remember guys, if you have not placed an advanced airway, 30 compression, 2 rescue breaths. But if you have placed an advanced airway, you have to give 1 rescue breath every 6 seconds. Every 6 seconds. And the other person has to just continuously give compression. So how many rescue breaths in 1 minute? 10 rescue breaths per minute. Okay? Whereas case of pediatrics, in case of advanced airway, how many rescue breaths guys? It should be 20 to 30 rescue breaths per minute. That means every 1 rescue breath every 2 to 3 seconds. Okay? So ventilation to compression to ventilation ratio in case of newborn, it should be how much guys? 3:1. Okay? Now, this question to you, when is this position used guys? This is basically regarded as what position? Recovery position. When do you use this position? When a person is having pulse. Imagine a patient has collapsed. When a person, and you check the patient pulse is there, breathing is there, but he is unconscious. Just in order to prevent aspiration risk and all, you keep the patient in what position? Recovery position. Okay. Now guys, during cardiac arrest and all, we follow an algorithm, ACLS algorithm. Just briefly going through that algorithm guys. Remember, in algorithm, you start the compressions and all. As soon as defibrillator is available, okay, you finish your 2 minutes of compression, and once the defibrillator is available, you check for the rhythm. Okay? If the rhythm is shockable, you go for the shock. Remember, shockable rhythms are 2 rhythms. This is ventricular tachycardia and this is ventricular fibrillation. VT and VF are shockable rhythms. Rest all rhythms in cardiac arrest, whether asystole, whether normal sinus rhythm, that is pulseless electrical activity in cardiac arrest, these are non-shockable. So when you are starting a shockable rhythm or shockable algorithm, always remember, after 2 shocks you start adrenaline, and after 3rd shock you give amiodarone, and then rule out 5 HS and 5 Ts. 2 shocks adrenaline, 3 shocks amiodarone, and ruling out reversible causes of cardiac arrest, 5 HS and 5 Ts. Okay. Non-shockable rhythm, we'll discuss later how to manage that. Okay. So 40-year-old cirrhotic patient requires muscle relaxation, and which is the fastest acting muscle relaxant? No, fastest no. Which is the safest muscle relaxant in this patient? Okay. So answer over here is what guys? Remember, if a patient is having liver problem, you need to give a muscle relaxant that bypasses the liver and kidneys, and it is undergoing a magical metabolism. Only 2 muscle relaxants are there. Only one is given over here, that is atracurium. Okay? So atracurium and cis-atracurium undergoes Hoffman degradation. That's why they can be safely given in cirrhotic patients. Now guys, regarding muscle relaxants, we have to remember, in muscle relaxant 2 categories are there: non-depolarizing and depolarizing muscle relaxant. Whenever we are giving the patient general anesthesia, after making the patient unconscious, we have to relax the muscles. In muscle relaxant, there are 2 categories: depolarizing and non-depolarizing. In non-depolarizing, again 2 categories are there: benzyl isoquinoline and steroidal is there. In benzyl isoquinoline, they are usually ending with the term curiums. One is atracurium. Next is cis-atracurium. Remember, when atracurium came into the market, everyone were the fan of atracurium. Why? Because it was undergoing a magical metabolism called as Hoffman degradation. Okay? So it was not metabolized in the liver and nor excreted through the kidneys. But after some time, they noted what atracurium was having two side effects. What two side effects? One is it was causing histamine release, and other is it was forming a compound called as laudanacine. Laudanacine was leading the patient to seizures. Due to this, the anesthetist told we won't use atracurium. Instead of atra, they researched and they came up with the next drug, which is cis-atracurium. Cis-atracurium is also undergoing same Hoffman degradation, but it is having less side effects. Then came the other muscle relaxant, which is mevaquirium. Mevaquirium was regarded as the shortest acting muscle relaxant. Next came the doxycurium, which was regarded as the longest acting muscle relaxant. So how to remember Meva? Remember atrac and cis-atrac, Hoffman degradation, you have to remember, it's very easy. Shortest and longest, how should you remember? My short dog has long tail. My short means what? Mevaquirium is the shortest acting. Dog has long tail means doxycurium is the longest acting muscle relaxant. Okay. Then after, but remember doxycurium is most toxic. That's why we are not using. Instead of doxa, we are using second longest acting muscle relaxant is what, guys? Pancuronium. Pancuronium is the second longest. Next is rocuronium. Next is vecuronium. Now pan, rock and vecuronium, what we need to remember. When we are writing pancuronium starts with the alphabet P. Remember guys, P, you add a stroke, it becomes R. Pancuronium, you have to remember RRR, or you can easily remember the movie RRR. RRR movie was Rajamouli movie. RRR was what? Pan India movie, the one which won Oscar. Okay, RRR was a pan India movie. Okay, so pancuronium P, you have to remember RRR. R stands for what? Renal. Pancuronium is having maximum renal excretion, hence it is contraindicated in renal failure. Okay. Next is what, guys? Recovery. Now how is the recovery with this? Remember, pancuronium is the second longest acting, hence the patient will have a delayed recovery. Next is what, guys? Rate. Pancuronium increases the pulse rate and BP. Hence, pancuronium is regarded as what? It is regarded as a muscle relaxant of choice in shock. Muscle relaxant of choice in shock. Okay. Next is what, guys? Vecuronium. Vecuronium is the most cardio stable, guys. Vecuronium, I used to remember vecuronium as V of Valentine's Day. V of vecuronium looks like heart. It is the most cardio stable muscle relaxant, but it is having biliary excretion. It is the most cardio stable muscle relaxant. Can be used for cardiac patients. Rocuronium. When anyone tells you rocuronium, remember rocuronium is what, guys? Rocuronium is the fastest acting muscle relaxant. It is the fastest acting muscle relaxant, or you can say rocuronium rapid onset. RO of rocuronium, rapid onset, is equals to fastest acting muscle relaxant.